Yeah. So we
Yes.
go on to the next set of talks. Sorry, Shreyas, since both Dr. Suven and Himanshu are there, it's going to be that talk. I had misinformed you. We shall now have Dr. Suven Bhattacharya, who's a senior consultant from 9 Eye Center, Kolkata, and a truly amazing surgeon and an innovator. And we know that the BX ring has gained worldwide popularity with the ingenious thought process of Dr. Suven. And we have with us Dr. Himanshu, who's again a senior cataract surgeon from Vision Eye Center, Mumbai, who operates only on the VVIPs, I believe. So with some top people talking on a complex topic, I'm sure we are going to have lots to learn on how to be very safe in a small pupil. So Dr. Suven is going to talk on Phaco and his approach in small pupil. On to you, doctor.
Yeah, thank you very much, Dr. Chitra and the entire ARC team for this invitation. So we'll be discussing my approach to small pupil in Phaco, and we would like to take care of both pre-op non-dilating pupils and intra-op miosis. I do have a financial interest in the BX, whatever little I speak about it, and I do acknowledge Dr. Deepak Magor's contribution. I hope my screen is visible.
Yes.
Yeah, okay. So I look at very objectively preoperative considerations, intraoperative considerations, and postoperative considerations. So if we look, we are mostly concerned about the comorbidities that may also affect how the people behaves. So we would like to take that age into account, diabetes, hypertension, cardiac disease, medications, because now we know there are a host of conditions which cause IFIS, and it's just not tamsulosin. And of course, uveitis, glaucoma, and pseudoexfoliation and other eye surgery, the previous eye surgery, that is. And I would like to prefer to actually note it down, especially in facilities where there are multiple surgeons. One person takes the history and examination, another person does the surgery. It's imperative that we note it down objectively. Now, that is the list of drugs that can cause IFIS and conditions. So no amount of history taking can prevent surprises, but then definitely we could be better prepared. So that would serve in useful, but at least you have the backup and plan B in position. So there is a question which I always pose in all of my talks is what is the safe pre-op pupil size to eliminate the risk of IFIS? This paper in 2011 pretty much told us that for a pupil 7 millimeters smaller, the risk of IFIS existed regardless of alpha adrenergic receptor antagonist treatment. So that's 7 millimeters. And for those of us who think that IFIS is not a big deal in India, well, it's the risk, the incidence of tamsulosin intake and IFIS is much higher. And it has been documented that this is a wonderful paper. It's a landmark paper over here. And that these are important. Hypertension also is an important risk factor. This is, again, another landmark paper by Chang and Campbell in 2005. What we probably, a lot of us miss to read between the lines is, unlike the non-elastic, this is stated over there, exactly picked up from there, unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So now, that means there is something called a rigid pupil and elastic pupil, and the problem is that it's in the cusp in between and traverses all these three entities. So the elastic pupil is very much like a rubber band, it's stretchable. Any expander will work. Now, the rigid pupil is very much like a string, and it is not stretchable but tearable. So you need a strong and bulky pupil expander or a Kuglin hook or something bimanually to tear it. I would divide my strategy into preparation and implementation. So pre-op in NSAIDs, there is a lot of literature which supports that if you like to use it. Every eye is an IFIS candidate as far as I'm concerned until it's proven otherwise. So release posterior synechia, more importantly, the total posterior synechia and peripupillary membranes, intracameral injection if that's your choice. And I would like to actually most importantly distinguish between the elastic and non-elastic pupil, and we'll come to that very soon. So when it comes to implementation of my strategy, I look at the elasticity and choice of pupil device. So whether I go for OVD or iris hooks or pupil expanders, Viscoelastic, I would suggest, should be used very judiciously, and you should have a plan B in position and activate it whenever required. And now we have a choice of iris hooks, pupil expander, and post-op medications to follow up. So from that paper from Chang and Campbell, we know that pupil stretching is not effective in IFIS, which is an elastic pupil, and controlled stretching before the expander is probably helpful in rigid and fibrotic pupils. But then there is a lot of common ground between the two, so that can make it very confusing. So we have among devices iris hooks and the pupil expansion rings, the Milligan ring, the BX, and there are many more in the market. A word or two about IFIS. There are two components, the miosis part and the iris prolapse. Now, I believe that iris hooks and pupil expanders work very well. They provide a constant pupil size, good visibility for safe phaco. Now, iris prolapse pretty much depends on the IFIS severity and the pathological damage to the iris. So no device actually helps. If you have not had iris prolapse, it's just that your lucky day that it was a lower grade IFIS. That we must bear in mind. So how would I check elasticity of the pupil? Look at the video here. You inject BSS as soon as you do the paracentesis and you see that pupil expand. And that is an acid test that that pupil is stretchable, it's elastic. Now look at the video on this side. This pupil, you can inject as much BSS as you want. That pupil does not budge. It's not the shiny case, just the rigid pupil. See that fibrotic membrane. Now you do that stretch. And once you've done that controlled stretch with two Kuglen hooks, you have a reasonable stretchable pupil. You converted it more into a stretchable and a cosmetically more appealing pupil. So a favorable device in IFIS would be something which requires a small incisions, is thin and low vertical profile, and can exit through the side port. So the choice of pupil expander would depend on how you wish to tear the rigid pupil. It's a very personal choice. And so with two Kuglen hooks, it's controlled tear, a BX or any other thin device would be, it occupies a lot less space and helps in easy movement of instruments. Now, when you do it with a pupil expander, the problem is it's a little bit of poor control and you might have asymmetric tears, the Mulligan ring or the APX or the eye ring. It's a little bulky and occupies more space in the anterior chamber, but that's your comfort level, whatever it suits you. For a subluxated cataract, there is no two opinions about it. I would absolutely go for iris hooks because it allows me asymmetric pupil expansion in the quadrants where my subluxation is there, and I can play around that and add as many or remove as many as I want as the surgery progresses. Intraop miosis, again, I believe iris hooks and the BX would be the ideal choice. So the advantage over here with these two sets of devices is that you can safely engage the pupil margin without catching the capsular rhexis because you have instant confirmation as you engage the pupil margin. And the control is at the site of the crisis. That's the pupil margin. This is something I always show, that I would like to inject viscoelastic under the pupil margin and elevate it and keep that anterior chamber a little shallow. And that overfilling actually can be counterproductive. So that is an important message that I would like to convey. Nothing against iris hooks. I have contributed significantly even to the development of iris hooks. Madhu Instruments is the largest producer of iris hooks as of now, not only in India, probably globally. And Amit would be happy to tell you how much I've contributed to that. But that given, I would also say that there are certain downsides. There is a risk of infection, and there is a sphincter tear possibility, and the corners are absolutely wasted spaces. We really don't need to do stretch as much and waste those corners. The iris plane, the pupil plane is raised to the limbal plane, and that may cramp you in the anterior chamber, especially with the shallow anterior chamber. You might have a tough time and may cause iris trauma and endothelial damage. There is a paper which suggests that iris hooks take more time than pupil expanders, but then again, depends upon how comfortable and how long have you been doing either. So probably in India, the time taken is pretty much the same. There is a possibility of certain marks on the iris and disfigurement of the pupil margin. The BX has been validated over and over again, and these are the papers in JCRS and IGO, and it's on some other international journals. So how big do you want the pupil to be? That's another question. Hard cataract, we want it to be as big as possible. Why do we want it that way? I mean, any device that gives us an assured 5.5 would be good, because we are all very competent surgeons to do cataract through a 5.5, given the fact that it will not come down more than that. So a pupil device should just achieve that. Let's look at this video from Deepak Megur. This is a rigid pupil exfoliation hard cataract. That's where we started. And BX, which provides you nothing more than 5.5. You just can't get more than 5.5. Try whatever you may. So you may make it a little oblong and get a little bit more than 5.5 in one particular axis, but then overall the circumference, that's given with every pupil expansion device. So, and that's a pretty hard cataract, as you saw, and it's not a big deal. You can chop the cataract into as many fragments as you want. Intraop miosis. Now here it becomes a little tricky because the capsular rhexis margin is there and you really don't want to engage that. So when we inject viscoelastic under the pupil margin and separate that, lift it off from the capsular rhexis, that rim of capsular rhexis, With a thin device, you can, and which with the control of the pupil margin, you can actually push it under the pupil margin and over the capsular axis and actually have instant confirmation by pushing it more to the periphery. And if you have not engaged the capsular axis margin, you are absolutely sure that you've not done, because you're seeing it. With other devices which are remotely controlled, it's a little bit of a problem. Femto laser, this is something which was there in the publications earlier. This is 2015. All femtosurgeons over here will kind of, mostly I think they will say that this does not happen anymore. I think it's open to discussion. Incidence of stereophakic cystoid macular edema is known to happen with use of any device for pupil expansion, compared to when nothing has been used for device, and it was a well-dilated pupil. So there could be multiple reasons for that. I would like to follow them up with closely for a little bit any signs of uveitis and probably a possibility of CME in the post-op period. So the important take-home messages would be: I would like to identify pseudoexfoliation and associated comorbidities. I would like to differentiate the rigid and elastic pupil. And it's not the size of the pupil, it's the elasticity which matters. We must lower our threshold for using devices. It's not a really very pleasant situation if you land up in a problem just because you chose not to give that extra 30 seconds or 1 minute for a surgery, because that can cost you very dearly and cost you another half an hour. IFIS is associated with alpha blockers, hypertension, and many systemic diseases. And I believe strongly that iris prolapse in IFIS depends on the severity of the IFIS and not really the pupil device. And always have iris hooks or pupil expansion devices in the OT. Whether you choose to use them or not, at least you should have a plan B in position. I would strongly encourage everyone watching to read these 10 tips in emulsification in small people. It's pretty exhaustive. Thank you very much once again, Dr. Chitra and the ARC, for this wonderful opportunity.
That was a wonderful talk, a superb talk, Dr. Suven, and you managed to...
Thank you, sir.
3 cheers to you.
Thank you.